And without further ado, I'll hand over to Reverend Dr. Alfred Vanier, please.
Thank you, Yogi, and thank you everybody who's here. Thank you, Richard and Gloria. Sorry for the technical difficulties, but there you are. Yes, Kaj asked me to talk to this topic, diversity in the health workforce, and specifically drawing out some points that has come out of the recent Royal College of Nursing survey. But before I do that, I would really like just to put it in the context of, first of all, my own ministry, and of course in terms of Catholic social justice context. The people experiencing, Gloria, if you can put the slide up, please. Yeah, the next. So the topic is diversity in health workforce, experiences of abuse, bullying, and barriers in career progression. How can this be addressed? I mean, the poor in our midst, those experiencing inequality, those who are marginalized were in our midst. And we hear in the church's document, Lumen Gentium, the teaching on preferential option for the poor, which is about the seeing the face of Christ in the face of those who suffer and responding to them with love. And also Pope Francis emphasizes this in his encyclical Evangelii Gaudium, which is the joy of the gospel. And he says, without preferential option for the poor, the proclamation of the gospel is meaningless. So really, the point I'm trying to make is that the poor are not just those who are in developing countries that we often think about, but there are those who suffer marginalization who are in our midst. And this is a context in which I want to set the issue around inequality that affect healthcare workers. Can we have the next slide, please? I just wanted to reflect on the period during COVID pandemic, where as a chaplain I had to deal with a lot of issues. You would have heard during that period in Britain about the disproportionately high numbers of Black and Asian minority ethnic healthcare staff who sadly contracted and died of COVID. We have large numbers of nurses recruited in many of our hospitals, large numbers of nurses from the Black and Asian and minority ethnic background recruited from various places like India, the Philippines, Africa, and so on. And we heard about, during COVID, we heard about the problem of lack of personal protective equipment. I mean, that affected all nursing staff and healthcare staff. But what was striking was that our Black and minority ethnic staff were reluctant to complain about these issues, and therefore they just trudged on. And we know from previous data from the NHS NHS workforce race equality standard, this was 2019 prior to COVID. It shows that many Black and minority ethnic staff in the NHS trust across England reported personally experiencing discrimination at work from managers. So it's not surprising that they are reluctant to report some of these things and to complain. And these, to me, are social justice issues which we can't escape from. Can we move to the next one, please? So some of the things that I did was to raise awareness by taking part, for example, in a Radio 4 program, so that there was an awareness of some of these issues. And secondly, as a hospital chaplain, we worked with, I had one of the chaplaincy teams in one of the hospitals here. We made sure that the chaplaincy team looked out for vulnerable staff and supported them. And we picked up on their concerns and fed some of these concerns up to senior hospital managers. And in fact, in our hospital, that made a difference to quite a number of the staff. And we had pastoral support sessions with nurses and staff, especially those who were recruited from abroad. There were some who were stuck overseas, were not getting enough support from their hospital here. And we made sure that those concerns were picked up. And I've been working with the Equality, Diversity, and Inclusion team in the hospital. And now they've agreed to create a staff faith and belief support network through which we can support, in addition to the chaplaincy. This is now a recognized staff support network, which we hope to work with alongside other staff networks that specifically address issues around Black and minority ethnic staff, as well as there's a particular network that works specifically with women and so on. But we wanted to bring that faith perspective in it, and that's going well. So that's really in terms of just giving you a flavor of some of the things I've been doing with colleagues and some of the experiences during COVID, which actually laid bare some of the marginalization that happens within our NHS institutions. So can we move to the next slide, please? So moving on to the Royal College of Nursing Employment Survey. The report outlines results of a survey that was done in 2021, although it's been reported this year, and it surveyed the Royal College of Nursing surveyed 10,000 nursing staff from across the country. I think you were sent a link to this survey, so you may have already read it. It highlighted really stark differences in career progression and in treatment in the workplace between white nurses and those from mixed ethnic backgrounds and Black and Asian nurses. It focuses on 3 areas: physical and verbal abuse, bullying in the workplace, career progression, and work patterns. And I think I'll just talk a little bit in terms of what the findings in those areas are. Can I move to the next slide, please? A key finding is that 64.3% of nurses reported experiencing verbal abuse. These physical and verbal abuse are actually from patients, and Black nurses were more likely to report having experienced physical abuse. Black nurses who responded, both those working in the hospital and the community, were more likely to have experienced physical abuse than respondents from other ethnic backgrounds. So with this, there's actually, if you look at the report, you'll see one particular quote from an agency nurse who said, "I get touched up frequently at work. I've mentioned this to line managers before, and it just gets brushed aside." Yeah, so it kind of shows you the lack of support. Obviously, patients sometimes, obviously there's no excuse for that, whether you're a patient or not, but at least the managers should be there, supporting the staff. Can we move to the next one, please? In terms of bullying in the workplace, now this is bullying from colleagues, not from patients. A third of the staff reported they'd experienced bullying, and harassment, and this has often been linked to their age, ethnicity, gender, disability, and so on. And it's been mostly nurses working with agencies within hospitals, and those working with other NHS commissioning arms. What used to be the primary care trust, now they're called the commissioning, the CCGs, commissioning groups. And some of it, if you read that section of the report, you'll find quotes from nurses. One says, "The bullying, harassment, and bad treatment have received has left me scarred forever. They made me look at nursing in this country in a very different way." And then it goes on to say, my family and I will be leaving this country in the next 1 month or 2 months, leaving my country to come here as a nurse was the worst decision we ever made. You know, so that's somebody who had come here with high expectations and was faced with that. Can we move to the next one, please? In terms of career progression, again, there is this disproportionality where Black and Asian nurses were less likely than white respondents and those of mixed race, mixed ethnic background to have received promotion since the start of their career. And 3 out of 10 nurses who responded say that career progression opportunity, that there were no clear career progression opportunities in their current job. And it's clear that full-time workers are more likely than part-time workers to think they have opportunities for progression. And if you see in the report, most of the full-time workers are men, and the part-time workers are women. So there is that kind of disadvantage in that regard. And in terms of progression, one clear quote which I identify with, because in my work providing pastoral support to nurses and other staff, we come across this. It says it's around organizational culture within the NHS. It says, this person says, closed culture. Person is already known who will get the post. That's when it's advertised, despite interviews being undertaken. So you find that interviews are just going through the motions, but you find people appointed on the basis of who you know. There's another quote which talks about bullying. If you speak up, then you're unlikely to get promoted. So all these are the kind of organizational culture that we're talking that tends to breed discriminatory practice. So in conclusion, I would like to say that the survey further exposed, if you go to the next slide, please, the survey exposed really vulnerabilities and inequalities that's in our midst. And as Christians, the challenges has been not only of caring for, I've given the situation with COVID, but of being a voice of groups that are disproportionately impacted on by inequality. We need to look more broadly and more proactively in challenging such inequalities. And I was just reminded of Stephen, Saint Stephen, who stood in the midst of a very hostile crowd and boldly proclaimed the name of Jesus. And we are in a hostile, if we speak up, we are amidst hostility, but we mustn't be afraid. Also, Philip was in the wild, in the wilderness, and even the wilderness did not, bother him. He still proclaimed the gospel to the Ethiopian. He ended up baptizing that Ethiopian. So for us, responding to the pastoral needs of God's people by proclaiming his gospel beyond the confines of our parish walls is our responsibility, though challenging. And at the end of the day, that is the mission, is the missionary call that Christ commanded us to respond to. Thank you very much. So that's really a highlight of my presentation. But perhaps I'll put some questions here which you may wish to consider. against this background, if we can share what we have done, or we can explore what we should be doing in our local communities to support healthcare workers who are faced with the kind of inequalities that that we have highlighted. Or we can, and also how can we influence healthcare institutions in our local communities to address such inequalities. As a primer, in response to this report, the Royal College of Nursing called on the government to reform human rights law to help tackle workplace racism, including introducing legal requirements to eliminate disparities in recruitment, retention, and career progression. So is this something that as a group, CAJ or you in your own local communities could engage with so that such legislation is strengthened? So that, so those are just primers in some of the things that I thought you may wish to consider. So thanks.
Thank you very much, Reverend Vanya. I appreciate your giving up the time to prepare all of this and to do it for us. I'm just wondering, before we go into the two questions, I wonder if there is anybody here that would like to pose a question or make a comment before we go into the actual questions that have been prepared for you. I can't see everybody, but I know Gloria can. So if you have a question, Sue has a question. You'll have to unmute, Sue.
Unmute, please, Sue.
Gloria.
Yeah.
You can take the slide down, I think.
Yes.
Okay. We might need to see the questions, but.
Oh, right. Okay.
We'll need a question later, but not immediately.
Okay.
Yes, when you said about creating, Alfred, a staff network for support,
yes.
Did that include doctors as well as nursing and more junior staff?
Yes, it's open to all staff.
And so that the doctors also were experiencing.
That's right, and we have had quite a lot of difficulties in trying to get the doctors engaged. So what we have done is on the 27th of March, we have identified doctors who are positive as our allies to attend a webinar, which will be conducted by Dr. Barnabas Asprey from King's College London around the question, is medicine compatible with faith and belief or not? Basically targeted at doctors to try and engage them as part of, a part of being involved in the network. So it's those kind of activities we are continually trying to put in place to engage as broad a section of the staff as possible.
Mm-hmm. And then also when you talked about a huge proportion suffering furloughs, was that from patients mainly or from other staff also?
The statistics that the survey gave in terms of physical and verbal abuse was in relation to patients.
Mm-hmm.
But the link to that was that when patients behave in that way and staff reported to their managers, mm-hmm. the managers don't do anything.
Oh.
Sometimes, at least if the staff felt supported, then they could confidently raise that continuously. So you find that staff go suffering this without raising it because they know that when they raise it, the managers don't do anything.
Right.
Mm. And that's what the report says.
Mm-hmm.
And incidentally, today, as I was preparing, there was an incident which happened where a staff member was abused in that regard and told to go back to Africa.
Well, that's good. The NHS will suffer even more then.
Yeah.
That's sad. Thank you for that, Sue. Richard wants to ask the next question. Richard?
Alfred, thank you for that. Have you personally experienced any sort of discrimination, abuse, whatever? And how have you as a chaplain been able to support others?
Yes, I have experienced discrimination. Let me say abuse from patients, no. Let me say marginalization and discrimination institutionally, yes. I'm one of the few Black heads of chaplaincy, especially in a major hospital. And previously, places that my former white colleague, like high-level meetings where he used to attend, I have basically been excluded from, and it's been a fight to try and get me as head of chaplaincy, not as Alfred, but head of chaplaincy, to be in those, to be in those meetings. So that's the kind of organizational, institutional marginalization that I have personally, I continue to experience. Yes. And I openly speak about this because I've got allies in senior management positions who have been raising the issue, and it's totally unacceptable. Yeah.
And how have you found yourself as a chaplain able to support others in this particular area?
Well, yes, as a chaplain, it's really through drawing. That's why I put this in the context of God and drawing deep in terms of my own faith, and being able to go forward and say, look, this experience itself is part of me realizing what others might be going through, and therefore it's my responsibility to be alongside them and support them. So it's in a way, it's kind of spurred me on in terms of supporting those who face marginalization. That's why myself and my colleagues immediately set up this meeting with during COVID with particularly nurses who have trained abroad, to hear their voice and pass it on to the senior managers. It wasn't within a formal structure within the organization, but we felt that it was our pastoral role to do that. Yeah.
Excellent. Thank you for that. Anybody else with a question or a comment to make before we go to the questions?
Yes.
Fraser?
Yeah. I met this Indian nurse recently, and she said she was run off her feet, that there should be much more staff in her ward than there was, and they all had to try and do the best they could. So I think that it is very difficult to work in the NHS now because they're lacking so many staff, and they're suffering from burnout, a lot of them. And it is just kind of not acceptable, really.
You're right, Teresa, and I think this report alludes to it. There's a part which says one nurse says when senior nurses leave, senior nurses at say band 6, 7 leave, she is at a lower grade, but she is asked to take up their roles. And she finds that those roles are not recruited to. So she continues at a lower band, taking up more responsibilities. And you get that, replicated, I think, in various parts of the NHS. I'm afraid to say, yeah.
Mm.
Mary, you're muted, Mary.
Does anyone think there is a way of challenging that? Because I can see that individuals feel obliged to take on doing all this extra work. But are there any legal grounds for opposing it, or I don't know, what can be done? What could any of us do that would, or as an organization, could CARG do anything?
Yes, that's the challenge, Mary. When I was preparing this report, I came across, because it was commissioned by the Royal College of Nursing, yeah? So their response to it was to call on the UK government to strengthen the human rights law to help tackle workplace racism. And they've asked that legal requirements should be introduced to eliminate disparities in recruitment, because they think that the law is weak on this.
Yeah.
Recruitment, retention, and also in terms of career progression, like this thing where, you know, it becomes, you know, for instance, at consultants level, you find very few women who are actually promoted upwards, you know. So it's an issue not just of race, but there's that kind of gender inequality as well. So it's about guarding against that. So so they want employers to have greater responsibility also to protect minority ethnic groups from racism and so on. So it's about looking at that human rights law. So perhaps organizationally, maybe that is something that an organization such as CARG could link up with the Royal College of Nursing to monitor what progress is being made in that regard in terms of their recommendation, and then identify where they might be able to support through their lobbying activities. And then CARG members within their own local communities could then also begin putting pressure on their own MPs and so on to see that this is, you know, this is moved forward. And at a local level is obviously offering that, being alongside, you know, the nurses and so on. So that would be, that's one of the openings I can see.
Alfred, I was thinking that, yes, that sounds exactly right. Could maybe CARG, do you ever do like press releases that would kind of reiterate what the Royal College of Nursing report has said, to say, we as an organization support the Royal College of Nursing demand for, and list again, it's just amplifying it so it doesn't get forgotten, just to keep it in the public eye as a demand. Might there be some way of, it's sometimes.
Well, I think Richard would like to just give it an answer to that.
No, it's not. It's about your mention of them suggesting that the Human Rights Act should be improved or something like that. I think if we get involved in this issue, we have to look carefully at what protections are in the Human Rights Act and what protections are missing, but also what protections are in our own UK legislation, the Equality Act, and what protections are missing. And if you put those two pieces of legislation together, do you have sufficient protection that is simply not being used, or are there needs of changing? And if so, which piece of legislation needs changing, or do both?
Yeah.
Yes, you're right, Richard. And
Hi,
that is,
sorry, I've come to the party, the conversation late, sorry. But just
You.
You're frozen, Nikki.
oh, sorry. Yeah, and I was just saying, I'm sorry I've come to the party rather late, just caught the end of it. Sorry, I was in another meeting, ran over. But it's been a very interesting conversation, and I absolutely agree with Richard. This sounds to me more like an employment law. I'll turn my camera off because I keep freezing, but hopefully you can hear me. It sounds a lot like it's linked to employment law and workforce, kind of equality issues around workforce equalities as well. So definitely a good idea to look at existing legislation, particularly bearing in mind the recent talk that we had on the Human Rights Act and the Human Rights Bill and the proposals to amend the Human Rights Act.
Thank you, Nikki. Just to go back to Mary, Kaj is writing up short briefings on every one of these workshops, and yes, it is being published.
Great.
You'll find them all on the website, and to a few we have actually sent it out to the press. So
Good.
yes, we are doing that. Okay, I think we have enough time now. If we can all go back to the first question. If Gloria, if you can put the questions up, please. And Reverend Alfred will take us through the first question, please.
well, we probably, I don't know, I was struggling to try and get questions together. So I've come up with this. The first one is, what have we done or should we be doing in our local communities to support healthcare workers? And when I posed this, I was conscious of the fact that for example, the NHS trusts, foundation trusts like the hospitals and so on, do have public membership that people can join. And they also have governors who represent community interests. So we may think that those organizations cannot be penetrated, but there are structures which provide opportunities for input, from the community. So really, I had that kind of thing in mind, and also other things that maybe some people are already doing or have already done. So I just wanted to put the context of that question, forward, just to maybe try and push the conversation forward. Yeah. So I don't know if anybody has anything to share on that or any suggestions to make.
Or if anybody's involved in anything like that. No.
Do we know, I should know, but are there Catholic organizations that work directly with healthcare workers?
Sorry, I missed that.
Are there Catholic organizations that work directly with healthcare workers? And maybe we could have a conversation with them. I don't know if they exist even.
There are associations of Catholic healthcare professionals.
Oh.
For example, there's an association of doctors, and I believe that I need to find out, but there are associations of healthcare professionals that come together, and St. Mary's University held a seminar on ethics representatives for some of those organizations attended one of the seminars that I was at. So there are organizations, there are Catholic associations of health, of health professionals.
Would they be involved in any of this work
I would.
on discrimination?
I'm not sure on this specifically, but I know that on the issue of euthanasia and the kind of threat of legislation coming forward to legalize it and so on, they are quite active in that. So on issues regarding various
Ethics.
rules that are being introduced or might impact on the practice of the various professionals, they are involved. So I would think that they would be involved in something like this. But I don't know. I don't have any idea, whether on this particular issue they're directly involved. But that's something perhaps that's worth finding out.
Mm-hmm.
I've never heard of them ever doing anything that seems to address hospital workers' day-to-day issues. All the years I've heard of the doctors' organization.
Mm.
I know that there was a social workers guild and there was a doctors guild.
Yeah.
Those are the two guilds that were. The doctors guild is still in place, although there's very few representatives coming to anything. And but the social workers guild no longer stands. So I'm just wondering, is there a nurses guild? Is there would there be a care workers guild? Because it's generally the lower end of the spectrum where people are discriminated against even more. So is there any chance of that being set up or bringing people like that together? Would the chaplains be able to help in any way on that?
That's perhaps something that we could look into in terms of the work that we are doing with the networks, because the Interfaith and Belief Network, as I said, works alongside the Black and minority ethnic staff network, and also with the women's staff network. And usually in terms of inequality issues that affect, and there's also the disability network. So perhaps it's through that equality, diversity, and inclusion group that perhaps our input through the interfaith network could begin asking some of those questions. Because after all, the equality, diversity, and inclusion team is resourced to do that kind of work. So maybe that's something that questions that I may go away and ask.
I know that you've started this in this area, in the Peckham area, in the Southwark area, but would this be true of other areas? I mean, would it be national? Is there any way of you, trying to permeate the other areas and getting people in the various dioceses to pick this up and to work with it?
Part of the terms of reference is to work with other areas. So once it's been a struggle to try and get it established here, but as soon as we are established, then we'll begin reaching out. That's the plan. Within various trusts, hospital trusts, you have standard staff networks, like for Black and Black, Asian, and ethnic minority. Very few for women, but we have already started one for women. There's the disability. There's the gay, bisexual, and lesbian network and so on. Those are kind of standard which you get in various trusts. But there, when I looked around, there wasn't any trust doing work around interfaith and belief staff network. A lot of belief, religious, non-religious practices was taken under Black and ethnic minority network. And my argument was that it's in as much as race and ethnicity is important, I think it's dangerous to conflate faith issues with that. Yeah. And hence I made an argument for specifically faith and belief network that works alongside all the other networks, so that if there are overlap of issues, then those can be discussed. But there are certain issues that specifically faith, whether you're Black or white, that need to be discussed. For example, during COVID, the issue of how staff were supported in their faith and belief within the institution was a real issue. Yeah. And there wasn't a forum to discuss it. Yeah.
Yep, that's true. Sue?
Presumably there are very large numbers of Muslim healthcare workers as well. So presumably your chaplaincy team includes them plus all the other representatives of religions.
Yes, we are a multi-faith chaplaincy. I was appointed not because I'm a Catholic. I was appointed basically because they felt that I could look after the people of all faiths, and ministers of all faiths within the team. Right. So we have got an imam, we have got chaplains from the Anglican background, we have got Baptists, we have got Seventh-day Adventists, we have got where we don't have them employed directly, we have faith leaders who are designated and authorized to come in if there is a requirement. So because like Lambeth, we have got a lot of Rastafarians. So we have got a Rastafarian person who comes and looks after Rastafarians. We have got Sikh, we have got Hindu, and obviously because of equality, we now have a humanist, what they call a non-religious, chaplaincy volunteer. But the person we have is very respectful of faith and so on. So he's a good, he's a good person. Yes, so that's how the chaplaincy works. So the chaplaincy is separate from the interfaith and belief network. In the interfaith and belief network, I've also encouraged associate membership from faith leaders in the community so that they can come in and bring their experience and so on into the organization. And that is something that the other networks don't have in terms of membership from outside. Yeah.
And do you find that the staff members, for example, who are being abused or suffering in any way, do they actually come forward to you to report things, or do you have to seek out this information?
Some of them come forward. Others don't, and their friends then sometimes indicate that somebody, they're under pressure and so on. And then we try and encourage the friends to find a way of talking to them and encouraging them to come and talk to us. And the fear normally is that if they complain, they will lose their jobs. Yeah, but we try and encourage them and say, look, especially those who have been trained overseas, who feel that they mustn't rock the boat. And we say, look, if you're unhappy and you're being mistreated, it's your right, to speak up, and we can confidentially support you in this. Yeah. So if gradually, then some of them gain courage and say yes, you can raise it with my manager, but others are afraid and just continue suffering.
Mhm. Can I ask again, please?
Yes, go ahead, Sue.
All these hospitals must be inspected at least from time to time. I know I'm putting it in the context of hospitals, and there are lots of other places as well. But like schools are inspected, these sorts of issues are always addressed by the inspectors. So what is happening that this should be so prevalent, all of this abuse and discrimination still, when surely all these health bodies have policies in place and can be inspected against the implementation of those?
Yes, and they're inspected, their yearly surveys, some of the data, for example, the NHS workforce data, which I quoted, regarding people reporting their managers bullying them, comes from that data.
Right.
And then there is an expectation that every year the trust improves. And that's there are systems in place, but the thing is, the question is, how effective are these systems? The CQC inspections are around services, are they being delivered well or not, and so on. But in terms of staff welfare, they probably don't feature in those kind of inspections.
Well, that's a shame, isn't it? Is it something that can be introduced? Is it something that somebody, some group could ask for that actually does happen?
Well, there is a leadership element of the CQC inspection, whether it's well-led. And the well-led aspect, I suppose, touches on that, but it's very high level. In terms of individual experiences, it probably doesn't pick up, on that.
I'm conscious of the time. And this is so interesting. We can go on and on the first question, but you do have a second question, Reverend Alfred?
Yeah, the second one was really, how can we influence healthcare institutions in our local communities to address inequalities and reflect these actions, in workplace practices. Yeah. And this is where I was basically offering I think, first of all, if I may just say, it's important for us to know our local healthcare organization. And also where there is opportunity for being a member, for example, if it's an NHS Foundation Trust, then that is a way of gaining access. And thirdly, if you know the governance arrangement, as I said, we have governors who have responsibility for representing communities. And if one can link up with them and then be able to ask questions. And as I say, for example, the workforce race equality data, which is generated every year, that should be a matter, data that members of the public can have a look at so that they can see how their own trust is doing. And if it's not doing well, then asking their representatives, just like you would ask an MP, to begin asking questions and bring the leadership of that trust, to explain. So really, my question was, I'm now answering it myself, but I was kind of just presenting it to see if something was happening there amongst the participants in that respect, and then offering that. But of course, yes. So I don't know.
Can I just ask a further bit onto that, Reverend Alfred? Is it possible for some kind of a toolkit from your group, you and the group, to a toolkit for parishes, so that parishes get a little more and understand? I'm just thinking, I didn't know so much. I didn't know anything about this now. So, and there must be lots and lots of people in our parishes who haven't any understanding that these are groups that exist and who need our support and help. So how do we get that information to the parishes? Would you be prepared to have some kind of toolkit that goes out to the parishes, and maybe a person from your group to go and speak in parishes so people can get some understanding?
Yeah, I'll make a note of that. I mean, from our chaplaincy, we try and link up in the local area with our parishes through having regular attendance, representation at the deanery, and then making sure that we have got agenda items to discuss for the parish priest then to take back to their parishes. And if needed, then we can be invited to parishes to talk about issues ourselves. We have tried that in terms of trying to increase referrals, because we were getting situations where people are admitted in hospital, their parish priest doesn't know they've been admitted. We are then called when it's the last moment and they've been in the hospital for 6 weeks, and we are saying that, look, we need liaison people within parishes who, obviously with the permission of the families, can then inform chaplaincy that so-and-so is in the hospital and needs support. So that's just an example of the kind of thing we work through deaneries. So with this as well, if you see it as something that might help, then I can see if I can talk with my colleagues and we develop something. Yeah.
I really do think it will, because even chaplaincies, I find that we look after a number of people in our parish, and it is very, very difficult for very often the local priest, the parish priest, and the helpers don't actually go and visit these people. And if you speak to the parish priest, you say, "Oh, get in touch with the chaplain." Now, parishioners could have been in the parish for 40, 50 years, and they know the priest, but then they've got to actually talk to somebody whom they've not met or don't know. So if there was a liaison, if there was some kind of contact between the chaplaincies and the parishioners in parishes, that would really be helpful, because then there's a two-way support. They can support the work going on there, and they know a little more about what is going on, and where there are difficulties, they could help if they knew how.
Yes, and similarly on this issue of things that affect the healthcare staff, if there are issues going on, then we can similarly liaise and say, look, in our local community, this is what's affecting our healthcare staff. They need your support, if it means.
All of these workers would belong to, not all, but most of them would be, members of particular establishments, whether it's a Catholic parish or another parish of another faith. But they'd all belong to some kind of a faith community, and the faith community should know a little more about them and support them. I'm so sorry, but on that note, I'm going to now say a very, very, very big thank you to Reverend Alfred. It has been wonderful. I've learned so much, and I'm sure everybody who's here tonight really appreciate and learned a lot from you. It's a pity we can't go on a little longer, but thank you again, and I'm sure that we will be calling on you again. So
Thank you,
very
thank
much.
you, Yogi. Thank you, Kaj. Thank you, everybody.
Thank
Th-
you.
This has been recorded and it will go onto our website. And when we've got a little briefing done, I'm sure that will go out too. Richard, do you want to say something?
No, this was great. Thanks very much, Alfred.